I'm here on behalf of Medicine 4 today, and I'm presenting my clinical meeting, and I've titled it Nicht Good. This is the case of a 60-year-old gentleman, Mr. N, who presented with complaints of fullness in the abdomen in the right lower quadrant, which was.
Is it one not Jahnawi one? We just turn off the light here.
Over here?
In the light. In the light. It's okay. In the red light off. Jahnawi, go ahead.
So a 60-year-old gentleman came with complaints of fullness in the abdomen, in the right lower abdomen for 4 months, which was gradually progressing and associated with a mild, dull, non-radiating pain. Other than this abdominal fullness, he did not have any altered GI symptoms. He did not have any vomiting, loose stools, any blood in stools. There were no urinary symptoms. He did not have any night sweats or fever. Though he did report some loss of appetite, he had not had any significant weight loss. This gentleman is PLHIV1 diagnosed in 1997 and on ART since then. Had virological failure and opportunistic infection with abdominal tuberculosis in 2008, after which he was on regular ART and with good virological and immunological control. He also was treated for pulmonary tuberculosis elsewhere in 2018, and that was the last infection that he had. And since March 2022, he was on dolutegravir, abacavir, and lamivudine, compliant to medication, and was doing well otherwise. On examination, the significant findings were of pallor, and in the abdomen, he had a firm to hard mass, which was 8 centimeters craniocaudally, 6 centimeters transverse, and it was located in the right lumbar and right iliac fossa. It had a smooth surface. I couldn't get below the mass, and it moved minimally with respiration. There was no palpable hepatosplenomegaly, and the trop space was also resonant. Rectal examination was normal. And other than him being a thinly built gentleman, his other systemic examination was also normal. So, differentials at this point. Wait, the slide.
Join event. No, that's not yours. Okay.
Yeah.
Tap the shutter button.
He did not have any peripheral lymphadenopathy, only, and no hepatosplenomegaly, only this right iliac fossa mass. It's not a pulsatile swelling. I'll move on. I think the differences that we had thought of have been covered here. So I did not want to keep the differential list very long, primarily thinking of, like everybody said, non-Hodgkin's lymphoma, other differential in that location being a colon carcinoma, and infection, ileocecal tuberculosis because of the location, the history of abdominal tuberculosis and pulmonary tuberculosis in the past. Appendicular mass and abscess was less likely because he did not have any history of fever or any severe abdominal pain, an acute event preceding this insidiously rising mass. Soft tissue sarcoma and any soft tissue tumor from anything in that location would be possible, but this was an intra-abdominal mass. Blood investigations showed this microcytic hyperchromic anemia. Other than that, lab investigations are within normal limits. I think I forgot to put the liver function test, which was normal with a normal protein and albumin. The gentleman's CD4 count was 124, but his HIV RNA was not detectable. So this is a 60-year-old gentleman who is a PLHIV1, but disease is well controlled, who has come with a right iliac fossa mass. This was the imaging, which showed this mass in the right iliac fossa, which with some air pockets inside it. It was contiguous with the bowel wall, but not necessarily arising from the bowel wall. In addition to this, there were other intra-abdominal lymphadenopathy, but no involvement of the liver, spleen, no involvement of. We had also done a thorax imaging. There was no other lymphadenopathy. So this was the report for the imaging: large mass in the right iliac fossa. And so we did an ultrasound guided biopsy. I will just go back to the slide. Can anybody, if nobody read the slide, can anybody talk about the specific type of lymphoma based on? I don't think I'll be able to go back without showing the answer. All right. So the immunohistochemistry was positive for CD20, which tells us it's a B cell lymphoma, which is also the most common type of lymphoma in patients with HIV and amongst non-Hodgkin lymphomas. And these cells in immunohistochemistry were also positive for BCL2 and c-MYC. So the diagnosis was of diffuse large B-cell lymphoma, and this was a germinal center B-cell subtype. This is the Hans algorithm for immunohistochemistry, with which we talk about differentiate between germinal B-cell type lymphomas versus activated B-cell type lymphomas. So you look for CD10 and BCL6 positivity. And these are markers of germinal cell B cell. And if these are negative and you find FOXP1 positivity, then you're thinking of activated B cell type. But this was a germinal B cell type, which is the more common one. So diffuse large B cell lymphomas are the most common non-Hodgkin lymphoma in the general population as well as in people living with HIV. Peak incidence is in the 6th decade. And outcome predictor is the International Prognostic Index revised version, which the original International Prognostic Index was published in 1997, I think. And after that, after initiation of RCHOP for these patients, the prognosis was revised. And all the things that matter in prognosis, or the most important things that matter in prognosis, are the age, the Ann Arbor stage, the performance status, LDH, and extranodal involvement. The challenges in our patients were that it seemed to be an HIV related but not an AIDS defining non-Hodgkin's lymphoma, because this patient had good viral suppression. His immunohistochemistry showed a double hit status, which is the MYC and BCL6 positive status. We wanted to know whether there would be any drug interactions with ART once we started the chemotherapy. And there was additional risk due to the location of lymphoma, as the lymphoma was contiguous with the bowel wall. So talking about non-Hodgkin's lymphomas in people living with HIV, the risk or the incidence of non-Hodgkin lymphoma has come down significantly after initiation of ART in 1996, but it still remains higher than that in general population. Outcomes in these patients have also improved after ART, and prognostic factors and outcomes are reaching something similar to those in the general population. Multiple studies have shown that it is safe and necessary to continue ART in patients who are undergoing treatment for lymphoma. And there are no significant drug interactions except with protease inhibitors, which are not in the current first-line ART therapy. This is a study of 110 patients. It's a retrospective study of 110 sequential patients with non-Hodgkin's lymphoma and patients who were living with HIV. Again, here the most common lymphoma was a DLBCL, like in our patient. Most of these patients had extranodal disease. Most of them were treated with RCHOP, and their median CD4 was 233. So the overall survival and performance, the progression-free survival at 2 years was equal, 75% in these patients. And this is similar to another cohort that they compared with in HIV negative counterparts of similar patients, with not very statistically significant, but it was similar. Poor prognosis again in these patients was found to be associated with a poor ECOG status, extranodal involvement, and the International Prognostic Index advanced status of that. So similar to that in a general population. Now, our patient did not technically have an intestinal lymphoma. It seemed to be arising from lymph nodes and be contiguous with the bowel, but we were again concerned about perforations once we started the chemotherapy. This is a fairly morbid complication seen in non-Hodgkin's lymphoma. So this single center study showed that of 1,000 patients with GI lymphoma, 9%, which is a fairly large number, had a perforation. And of the 55 deaths that were there in this cohort, 28 were due to perforation. So this is something that should be kept in mind when we are treating patients with GI lymphoma or lymphomas that are contiguous with the bowel. So our patient, because of the double hit mutation, is planned for RDA epoch instead of RCHOP, and he has been transferred to hematology. He's being monitored for tumor lysis, and we are monitoring for features of GI perforation, which is why we have admitted and he's undergoing treatment. So the take-home message is that incidence of lymphomas in people living with HIV has declined, but remains higher than in general population. So we should think about it when we're thinking of lymphadenopathy or lymph nodal masses. But outcomes have improved since initiation of ART. It is important to continue ART in patients who are being treated for lymphoma. We should keep in mind the additional risk of perforation and mortality in patients who have GI lymphomas.
Thanks, Jahnavi. You also stuck to time. That was interesting. Any questions, comments? I think something I'll share, which maybe Sudha also will identify, is when we were doing our PG, which I just calculated was 20 years ago, was even ART. The patient had to buy it, and it was very expensive. We had a counseling done and a bank account check before we actually gave them ART. And now looking at this, it's really pleasing to know that people can even get complications and still, because of ART, survive much better. So I think at least that much has evolved. Of course, the national programs are there, but I think just to look at the evolution in our country also is quite heartening. So thanks, Emily. I'll invite Hannah. Presentation from.
Just a comment.
Yeah, go
I
ahead,
think
please.
all chronic inflammatory conditions, like either diseases like SLE, HIV is also kind of like that. So